Welcome to PALS. It's Professor Anyanwu's Anatomy Lecture Series, where our only goal is to make anatomy simple. This is the part 2 of our lecture on the anatomy of the pleura. If you're just joining us, you have not subscribed, we would like to encourage you to please do and be a part of this amazing anatomy family. In part 1 of this lecture, we discussed the basic anatomical features of the pleura. In this part 2, we will be discussing the pleural recesses and clinical correlates associated with the pleura. So let's go to class. We will look at the pleural reflection. It's actually the outline made on the thoracic surface by the parietal pleura. At the points, it changed direction as it lined the inner walls of the thoracic surface. Let's look at some of them. These are those outlines, and these outlines are called the pleural reflection. There are 4 major lines of pleural reflection. We have the cervical, the anterior, the inferior, and posterior. We will start with the cervical line of pleural reflection. It is marked by a curved line which has an upward convexity. These are the 2 points, the point here and the point here. And then this is the curvature that is projected upwards. Now the points are drawn from first the sternoclavicular joint, that is this joint here, the point of the sternoclavicular joint, and the next point is the junction of the medial third and the middle third of the clavicle, and then this is at this point. This is at this point. The next reflection line is the anterior, which is also called the costomediastinal or the sternal line. Here is the sternal line or the anterior line. This is for the right, and this is for the left. Now, this line marks the junction between the costal pleura and the mediastinal pleura anteriorly. The 2 lines differ on the right and on the left. We'll consider the right side first. Now, on this right side, it will start from the sternoclavicular, the point on the sternoclavicular joint. That is where I have my light. It will extend downwards and medially from this right sternoclavicular joint to the midpoint of the sternal angle, that is from this point down to this point. This is the angle of Lewis, or the sternal angle. So the first journey we notice is the point from sternoclavicular angle to the sternal angle, and from the sternal angle it will descend vertically to the midpoint of the cervicosternal joint, and that is from this point to this point. So the right sternal line of reflection is a reflection from the sternoclavicular joint down to the sternal angle and then at the cervicosternum. We'll look at the reflection on the left side. From the left side, it will also start from the left sternoclavicular joint and will share the same course down to the sternal angle and then up to the 4th costal cartilage. At this point, its course will vary with that of the right. It will move laterally to the lateral margin of the sternum. As you can see here, it now takes a lateral course and moves to the lateral aspect of, get up to the level of the lateral margin of the sternum. From this point also, it will continue on its downward course and run as low as to the point of the 6th costal cartilage. Now, with this lateral deviation of the pleura on the left, there is a part of the pericardium that is left uncovered, and this part will be directly in contact with the anterior chest wall. This uncovered area is called the bed area of the heart. That is this area. We'll take a look at the inferior line of pleural reflection, and this is also called the costodiaphragmatic line of pleural reflection. This is for the right, and then this is for the left. Now this is the junction of the costal pleura with the diaphragmatic pleura. As we noted in the sternal line of reflection, it differs with the right and the left. We'll first look at the right. Now, before we look at that, I want us to understand some lines that will be very important in this inferior line of pleural reflection. And we'll look at it from this illustration. The line we have here is the line that is actually running through the clavicle, and then this line is called the mid-clavicular line. That's the mid-clavicular line. We also have another line that is running through the middle point of the axilla, and that is the line here, and we call this line the mid-axillary line. So these lines will come handy in our description of the cause of the inferior line of pleural reflection. So let's go back to our initial illustration. So we remember that the sternal line of pleural reflection stopped actually at the xivisternum. This inferior line will start from the xivisternal joint, of course behind the xiphoid process. It will cross the 8th costal cartilage in the mid-clavicular line, and also cross the 10th costal cartilage in the mid-axillary line, and then it also crosses the 12th rib at the lateral border of the erector spinal muscle. The erector spinal muscle is a muscle that is found on both sides of the vertebral column. We will consider the left. On this left part, we can recall that the last point we saw the left line of sternal pleural reflection is at the level of the 6th costal cartilage. At this point, it is about 2 cm lateral to the midline. Now, it will start from the level of this 6th costal cartilage, and then will run downwards and laterally. And it will assume the same course with the right from this point. That is running across the 8th rib, the 10th rib, and then close to the lateral border of the erector spinal muscle. The last line we'll consider is the posterior line of pleural reflection, which is also called the costovertebral line of pleural reflection. This is the posterior line. This line is seen between the costal pleura and the mediastinal pleura posteriorly. It will ascend from the end of the inferior line, which is 2 cm lateral to the T12 spine along the vertebral column, to the point 2 cm lateral to the spine of C7 vertebra. In this illustration, the pink-colored regions are the lungs, and the blue-colored parts are the unoccupied sections of the pleural cavity that we are referring to as the pleural recess. We'll look at the major recesses. There are 2 major recesses. One is the costodiaphragmatic recess, and the other is the costomediastinal recess. We have other recesses called the minor recesses. We have the right and left retroesophageal recess, and this is formed by the reflections of the mediastinal pleura behind the esophagus. We also have the infracardiac recess, which is actually a small recess of the right pleural sac, and sometimes it extends beneath the inferior vena cava. We will start with the costodiaphragmatic recess. The costodiaphragmatic recess is also called the costophrenic recess or phrenicocostal sinus. It is the largest and clinically most important recess, and it is found inferiorly between the costal and diaphragmatic pleura. Vertically, from here to here, it measures about 5 cm, and then it lies opposite the 8th to the 10th ribs along the mid-axillary line. Pleural effusion will first collect in this recess when in standing position, and then it will present on plain X-rays as blunting of the costophrenic angle. Now look at this radiograph. We'll first look at the normal radiograph. Now this is a normal radiograph. This is the diaphragmatic area, and here we're having the costal area. And then this is the point of the costophrenic angle. And here we're seeing the costophrenic angle or costodiaphragmatic angle. Now let's look at a chest radiograph that has pleural effusion. Here on this side we'll see the sharp costophrenic angle without pleural effusion. On this side, we can see effusion around this region, and then we can see the lungs pushed up, and here we are seeing a blunt costophrenic angle. So this is the appearance of the costodiaphragmatic recess during effusion, and this is the appearance of the costodiaphragmatic recess in a normal situation without effusion. We also consider the next major recess, which is the costomediastinal recess. The costomediastinal recess is located anteriorly between the costal and mediastinal pleura. It lies between the sternum and the costal cartilages. Here is that recess. Here is that recess. Now the left costomediastinal recess is expected to be larger, as we can note here. And then this is as a result of the presence of the cardiac notch. The cardiac notch is the shortening of the lungs on the left side. We'll consider the nerve supply. As we noted in the first part of this lecture, we said the parietal pleura is sensitive to pain, temperature, touch, and pressure, and as a result is supplied by the somatic nerves, which are the intercostal nerves and the phrenic nerves. Now the costal pleura is supplied by the intercostal nerves. The mediastinal pleura is supplied by phrenic nerves, while the diaphragmatic pleura is supplied by both the phrenic nerve and the intercostal nerve. The part of the diaphragmatic pleura that covers the dome of the diaphragm is supplied by the phrenic nerve, while the peripheral parts are supplied by the lower 6 intercostal nerves. For the visceral pleura, is insensitive to common sensations such as pain and touch, but are only sensitive to stretch. It receives an autonomic nerve supply from the pulmonary plexus. Now we'll consider the pleural fluid. We noted that the pleural cavity is normally filled with this thin film of serous fluid that we said is about 5 to 10 mils. And we also noted that the fluid lubricates the inner surfaces of the visceral and parietal pleura during respiration. The formation of this fluid is as a result of hydrostatic and osmotic pressures between the capillaries. The pleural fluid is normally absorbed into the capillaries of the visceral pleura. The formation of this fluid results from hydrostatic and osmotic pressures between the capillaries and are also absorbed into the capillaries of the visceral pleura. Any condition that will increase the production of the fluid or impair the drainage of the fluid will result in abnormal accumulation of fluid. And as we noted earlier, this condition is called pleural effusion. As you can note in this illustration, we're already having abnormal accumulation of fluid here, which is pleural effusion in this side of the lungs. Now we'll look at a condition called pleurisy. Pleurisy, in simple terms, is inflammation of the parietal pleura. Now when we look at this illustration, we are seeing a normal parietal pleura in this section, and then here we are seeing an inflamed parietal pleura. We are seeing an inflamed parietal pleura. So when this happens, it presents as pain, which is aggravated by respiratory movements, and it can radiate to thoracic and abdominal walls. The pleural surfaces will become coated with inflammatory exudates that will cause the surfaces to be roughened. This will produce friction and a pleural rub, which can be heard with stethoscope on inspiration and expiration. The exudates will become invaded by fibroblasts that will lay down collagen and will bind the two surfaces, will bind the visceral pleura to the parietal pleura. And this condition is called pleural adhesion. We will now take some of the clinical correlates associated with the pleura. The following pathologies associated with pleural cavity: we have accumulation of serous fluid, as we noted, which is called hydrothorax, and also pleural effusion. We can also have accumulation of air within the pleural cavity, a condition known as pneumothorax, or it could be blood, in which case it will be called hemothorax, or it can be accumulation of pus, called pyothorax or empyema. We will start with pleural effusion. We said it's excessive accumulation of fluid in the pleural cavity, and it's majorly due to inflammation of pleura. When this happens, it will lead to decreased expansion of the lung on the side of the effusion. This can be detected with decreased breath sounds and dullness on percussion on the site of the effusion. Now, the presence of up to 300 ml of fluid in the costodiaphragmatic recess in adults is sufficient to enable its clinical detection. And some of the clinical signs include decreased lung expansion on the side of the effusion. As you can notice here, we have effusion around here, and of course we're having collapsed lung, and there's decreased expansion of lung on this side, and this will lead to decreased breath sounds and dullness on percussion over the region. We'll look at a procedure called Turacosynthesis or pleural tab. This is a procedure by which an excess fluid is aspirated or drained from the pleural cavity. This is performed to the patient in sitting position. Usually, it is recommended that the needle be inserted along the 6th, 7th, or 8th intercostal spaces in the region of the mid-axillary line. The needle is passed through the lower part of the space to avoid injury to the principal neurovascular bundle. Pneumothorax, as we noted, is the accumulation of air in the pleural cavity. In this radiograph, we are seeing air accumulation around this region. As a result of disease or injury, air can enter the pleural cavity, and it can come from the lungs or it can come from the chest wall. Now, stab wounds on the thoracic wall may pierce the parietal pleura so that pleural cavity is now open to the outside air, and this type of pneumothorax is called open pneumothorax. We have a condition known as Refat pain of pleura. The pain from central diaphragmatic pleura and mediastinal pleura can be referred to the neck or shoulder, and this is through the phrenic nerves with roots C3, C4, and C5. This is because the skin at these sites have same segmental supply through the supraclavicular nerve that also shares C3, C4, C5 nerve roots. This is where we will end our lecture on the anatomy of the pleura. If you have questions, comments, or suggestions, please drop them in the comment section. If you consider this material helpful, we will encourage you to subscribe, like the video and share it to your friends, that it will also be helpful too. And together, we will build a unique anatomy family where our goal is to make anatomy simple. Thank you, and see you in my next